A capnograph is a small machine which measures the concentration of carbon dioxide in the breath during exhalation. This value directly corresponds, via a small conversion equation, to the partial pressure of carbon dioxide in the blood. Carbon dioxide is absolutely essential for the blood's pH buffering system. It dissolves into the plasma as carbonic acid and acts to maintain the blood's pH as close to 7.4 as possible. Cellular metabolism releases carbon dioxide into the blood, and exhalation releases it into the environment. Without a buffering system, blood pH would thus ricochet from acid to alkali rapidly, depending on how fast someone was breathing or how high their metabolic rate was. Whole body homeostasis, and therefore life, cannot sustain itself without blood pH being as close to 7.4 as possible. If we consider hyperventilation, technically defined not by mechanical rate of breathing, as one might otherwise imagine, but as breathing beyond the body's physiological needs, then it follows that such a state would cause breathing off of too much carbon dioxide relative to the person's net metabolic rate. Thus, the blood's pH buffer shifts its dynamic equilibrium to the range of being slightly alkalotic. Less of the acidic carbonic acid is available to take part in the buffer, and so the pH rises. If someone has pre-existing issues with their cardiovascular system, such a state can be fatal. But for the average healthy person, rather than being immediately life-threatening, it is nonetheless very well documented to cause an array of unpleasant somatic symptoms. Capnography, through measuring the concentration of carbon dioxide dissolved in the breath, is thus a highly effective diagnostic tool for uncovering respiratory alkalosis. In 1990 at Charing Cross Hospital in London, Steve and Pauline introduced clinical capnography and the Charing Cross method into NHS primary healthcare, specifically the psychotherapy, hypnotherapy, counselling and stress management provisions. Pauline had already been using it in psychiatry since 1989. Beginning in 1988, through original clinical empiricism, Steve and Pauline integrated capnography with their unique modality of hypnotherapy and their biopsychosocial model of complexes. Never before had capnography been used in a psychodynamic context. It had hitherto been deployed fundamentally in biomedical and cognitive behavioural contexts. By this time, they had already studied Janet's work on dissociation, Jung's scientific work on complexes, including his use of the pneumograph and the galvanised skin response, and Rossi had very recently published his 1988 book, co-authored with David Cheek, Mind-Body Therapy, which outlined his transduction pathways. Capnography, however, again never before deployed in a psychodynamic context, offered a new window into a person's internal milieu, which could be mapped in real time onto psychosocial and psychological factors through a broad clinical protocol. Instinctive frustration causes dissociation of the ego field. So too, hyperventilation, independently or coupled with instinctive frustration, also dissociates the ego field. Dissociation is the immediate precipitating factor leading to the formation of complexes. Thus, through their work on capnography, Steve and Pauline discovered that alkalotic blood pH, marked by hyperventilation, is one of the most potent state encoders of complexes. Respiratory alkalosis dissociates the ego field. A complex can form, and that complex will then subsequently always act to reconstellate the respiratory alkalosis as its setup conditions. Let's see this in action. On screen is a capnogram from a case conducted by Steve and Pauline on the 22nd of July 1991 with a female patient of 27 years of age. The x-axis shows time running from right to left, with each segment like this marking 2 minutes. So this whole capnography session took approximately 29 minutes. The y-axis shows percentage of CO2, with each percentage point corresponding to a value of 7.6 millimeters of mercury. The lower the millimeters of mercury, then the more CO2 the person is breathing off, which, as we've said, is a direct indicator of the blood pH shifting towards alkalosis, hence hyperventilation. breathing beyond the body's physiological needs. At the time this case was conducted, any value less than 29 millimeters of mercury was considered frank hypercapnia, with the normal range being 35 to 40. Steve and Pauline consider this too harsh a cutoff, but regardless of this, it's clear to see just at a glance that this patient's CO2 is fluctuating chaotically, with the vast majority well beneath any reasonable cutoff point for frank hypercapnia. Wherever you see dark shading, this is indicative of rapid breathing. The chart strip pen was moving so fast in correspondence to the breath cycle that it was literally just writing over itself. If we start from the right hand side, this point here shows the first breath detected by the capnograph. In this initial rest period, so just the capnograph detecting breathing at rest, you can see that the CO2 more or less immediately dropped into chaos. We can easily infer from this that the individual was hypercapnic at rest. This state, on its own, is sufficient for many psychosomatic symptoms to develop and progress. An alkalotic blood pH as a whole body state encoder of biopsychosocial complexes. Then, as was standard practice at the time, though Steve and Pauline soon after dropped it completely, as it's not needed, the patient was asked to go through a forced hyperventilation provocation test for 2 minutes. The purpose of this was to sensitize the patient to hyperventilation for a brief period of time, so that what would otherwise be very small changes in CO2 would be magnified in value, making psychophysiological rate of change easier to detect. As expected, the CO2 drops, literally because they are hyperventilating. The patient is then asked to report when their breathing feels normal again. That's the MBIN, my breathing is normal, in the notes at the bottom. They say that their breathing is normal here, despite a frank hypercapnic CO2 reading, meaning that they were positive for what's called failure of perception of hypocapnia. This CO2 level should not be felt as normal. Hence, this is indicative of a level of dissociation. A failure of perception of hypocapnia was synonymous, for Charing Cross at the time, with the sensitization that was aimed for through the forced hyperventilation provocation test. However, Steve and Pauline found, as we mentioned a moment ago, that this was not needed. It is entirely possible, through the psychodynamic process, again, of dissociation, for someone to believe that their breathing is normal, when in fact it clearly isn't, without any need for forced hyperventilation. Therefore, whenever you see MBIN for this patient, you are seeing dissociation. Then Steve moves into the think test. This is exactly what it sounds like. The patient is asked to think about a certain aspect or occurrence in their lives, selected before the session, and the psychophysiological response is measured by the capnograph. For the first think test, trouble at work, the CO2 value rises away from the restored baseline, being no longer chaotic, but then the breathing starts to grow rapid, and the chaotic pattern of breathing returns. Then they're asked to report when their breathing is normal, marked here. Then there's the think test for parents. Again, you see a fall in CO2, followed by a brief rise, then a fall, before the patient is asked to report when they feel their breathing is normal again. This section also picks up a breath-holding pattern from the patient, represented here by an incomplete line, literally an unfinished breath. Then for the final think test, abortion, there's a massive collapse in CO2 value, marking a strong abreaction. You can see the continued fall all the way down to beneath 7.6 millimeters of mercury. Charing Cross would have said that this person was at immediate risk of coronary artery spasm, or any number of potentially fatal cardiovascular events. The think test of abortion had revealed very starkly the etiology of her complex. The surrounding circumstances had not been disclosed by the patient to Steve in this initial capnography session, but the patient had been raped, leading to her conceiving a child. She decided to undergo an abortion. All of this, from the rape to the abortion, had wounded her significantly. She had been unable to understand, at the level of instinct, what had happened to her. Instead, her ego partitioned through Jungian dissociation to deal with the instinctive pressure. That partition had remained, as a Jungian complex, state encoded via an alkalotic blood pH, extremely likely the exact conditions under which it formed, i.e. acute hyperventilation. This complex was then activated at the mention of abortion, immediately constellating its original setup conditions of respiratory alkalosis. This shows definitively that complexes truly are biopsychosocial. The rape was later disclosed in the immediate follow-up session. Steve and Pauline will discuss the psychodynamics behind this part of the capnogram later on in this chapter. To restore the patient's breathing back to normal, as this had suddenly become an acute emergency, Steve began a hypnotic induction, which you can see start here. Immediately, there's a huge rise in CO2, back up to roughly the patient's resting value, followed by a period of 2 minutes, during which the abreaction perseverates, indicative of the state, the complex, attempting to resist the hypnotic induction. Then the hypnosis kicks in, and you see that trance state maintained for 5 minutes, with by far the most normal, regular breathing on the chart strip recorder. The hypnosis had encouraged very, very quickly homeostasis to turn the acute complex state off, and thus she was back to normal. To look further at this, we can see that the hypnotic induction lasted for 2 minutes. Once the patient entered fully into the trance state, then the rise in CO2 was sustained at a uniform level, at roughly her resting value. There has to be a transition period, that is the hypnotic induction, from a normal waking consciousness into a trance state. When someone is in a highly distressed state, like this patient, then trying an immediate induction is potentially highly risky. So she needed a period of time where her attention was drawn to the process of entering hypnosis, that's the 2 minutes, in which Steve was calm, relaxed, and paced. As soon as she entered into the trance state, the actual change took seconds. Steve and Pauline can provide more detail on this, as it's important to be aware of it.
I mean, there are hypnotherapists who rely on a kind of a rapid induction, aren't there?
Yeah.
I hate to say it, but often they are aggressive in the sense that they're boundary breaking, and they involve touching or leaning into someone, that kind of thing.
That's a really good point.
Which is to be avoided, because obviously that just is fuel for the transference.
It is.
But they tend to be the kind of things, almost like in a sort of a evangelical religious sense, when you get the laying on of hands, that kind of thing, where you touch someone on the forehead and they fall backwards. We don't indulge in that kind of thing.
Certainly don't. Certainly with a female rape victim,
absolutely not,
who has the same name,
yes,
or the rapist has the same name as the name of the therapist. You don't touch them.
There has to be clear boundaries.
There's got to be clear boundaries. And this is part of the way that we train people, of course, is to be very sensitive about the field of interaction and just what you do and don't do. But even so, around a minute for someone in that acute phase of a crisis, psychophysiological crisis, is rapid. It just is in seconds. But once the induction has got underway, then it is rapid. So it's not as if you've got someone who is dissociated with respect to being in a trance state, but is not altering their physiology, which is possible. You can have someone in a state and they're still hypnoidal state, and they are still suffering, but they're just not responding to the suffering. But removing the suffering when they enter the state means that the induction's been handled very well, and ideally so. So that, I think, is what you can see on the capnogram trace.
It was just impacting me how important that is, particularly in that scenario with a female rape victim and a male therapist. That could just go so horribly wrong and effectively re-traumatize her. So you did absolutely the right thing, and just to emphasize it, we don't advocate that kind of practice at all, whether it's a female therapist and a female patient, or any combination thereof. We avoid that kind of thing at all costs.
So you had the usual psychodynamic issues, and you had the acute, there's chronic crisis with an acute crisis overlaying on it, that was psychophysiological. So the way that you approach the induction is going to be really, really important, because you have to reach in past the noise. And by that, I don't mean that she was, screaming or yelling or anything like that, but I mean the systemic field noise. So many signals are occupying all of the receptive channels that a person has. You have to be able to get inside that, make an anchoring point, and then draw the attention of the person's meta-regulatory field, their homeostasis towards you, and then you develop the induction, and then you're in that state where they are separated off, and the physiological crisis itself collapses and normalizes. So in that sense, I would say a minute is very rapid, but it's not that usual rapid form of induction, which is aggressive, authoritarian and direct and performative as well.
Yes.
It's more like stage hypnosis than
it is.
the clinical management of a serious case.
Yeah.
Moving on to a few final details before we continue with this chapter. In the results box on the left-hand side, you can see that this individual was positive for chronicity or arrhythmia in breathing, positive for failure of perception of hypercapnia, positive for all 3 of the think tests, and positive for presenting symptoms. The pattern of the chart strip recorder, in accordance with what was asked of the patient, reveals the complexes involved in this person's state of resting hypercapnia and hyperventilation, their overall resultant suggestibility, how vulnerable they were, and most importantly, as shown by the hypnosis period, their capacity to heal. The case was ultimately successful, with the complexes resolved and the physiology returned back to health. It's clear to see how powerful capnography is for identifying the psychophysiological background state of an individual. Indeed, how powerful hypnosis is for bringing forward homeostasis against the inertia of complexes rapidly. Given what we know about this person's background state, it is worthwhile to imagine what might have happened had they sought out, for example, exposure therapy instead. It is very likely that this fall in CO2 here would easily have occurred. It would have gone undetected, except for being noted as an abreaction, and hence it would have been unmanaged, potentially leading to their death, either immediately or through a perseveration a few days or weeks later. Let's move on to an in-depth discussion with Steve and Pauline Richards on psychosomatic transductions, how they work, why they happen, and how to resolve them, using this case study as the backbone.
In that case study, would it be possible to highlight the instinctive elements that were going on for that person so that someone watching this can understand what a priori to those complexes forming was taking place or attempting to come through?
Yeah, if we take a conventional Freudian neuropsychoanalytic approach, then the young lady had issues with her parents. That's a classic Freudian scenario. And that had been maintained right through her life up to that point. She was age 27 when that capnogram was taken in 1991. Then there was rape, and then there was abortion. The rape was not within the family. It was an outsider. It was a relationship outside, which was one of rape, not of a consensual relationship or interaction, produced a pregnancy. And then there was an abortion. So we can see immediately then the Panksepian elements will be very, very strongly represented there, but also what we would regard as meta instincts and the context for the family. There's all sorts of ways a family can work well enough, but there are also very, very many ways that they can work badly and cause problems at an instinctive level. And that includes how a person's identity, and I mean that in an ego sense, not in any other sense at all, but how their identity forms, how their ego forms, basically. That can be very much influenced by early familial relationships. That's why over the past 120 plus years, the psychoanalysts have been focusing on that so much, which I think speaks for itself. Then when it comes to mating and relating, and how that might be interpreted at a Panksepian level, then to be raped and then for a pregnancy to follow from that, and then an abortion to follow on from that, and still the relationship to the parents is not what it should be. then that person was compromised at so many levels that meta-instinctively. So the context was present for Panksepp to fire, but those elements of Panksepp that were firing from affective neuroscience and neuropsychoanalysis were negatives. There was panic, there was grief simultaneously. There was issues of care and the negative side of care because of the abortion and who cared for her. She was abused. The Pankseppian play system, we would probably interpret through Anthony Stevens more about dominance in this regard. She was dominated and controlled, abused and raped, and then made the decision to not have the child. So you have instincts then at a fundamental Pankseppian drive state level at work. You have meta instincts, which can't make sense of those Pankseppian drives and therefore are present but not fully actualized, but are under instinctive pressure. And then you have the frustration of the meta instincts under Pankseppian drive pressure, which becomes the psychosomatic storm and then presented in her life as a drop-down menu of psychosomatic representations. And she was resistant to medications of all kinds, psychiatric support, psychiatric medication, counselling, clinical psycho, all of it, none of it had worked in the girl's unstable state. Our approach was that this girl has been severely dissociated through trauma. No amount of tackling repetition compulsion for these repeat nightmare experiences, that none of that has done anything or is likely to do anything. She needed to be put into a state of dissociation under which she was in perfect control and felt good about herself, but not away from the representation of the trauma. And the representation of the trauma came through the Charing Cross think test, as it was called, in this instance. And then because we had her on the capnograph, we could see just how dangerous her state was. And we were able to induce the altered state of consciousness, and then in that state build a therapeutic relationship, a state that could be re-accessed outside of hypnosis. This is key as well, that you continue on whilst you bring that person into a better state of orientation to themselves. So pretty much that's it. You've got meta instincts, which are important because they are scenarios that are anticipated at a genomic level. You have the failure of the meta instinct in the sense that it is only being represented negatively. And you have Pankseppian drives powering through and also not fitting properly because her own lust system didn't work, obviously. Her care system didn't work. Her play system, as they understand it in affective neuroscience and neuropsychoanalysis, was reversed because she was dominated and controlled, and she had no support from her family. They were judging her no matter what she did. And you can add on pretty much all of the 7 basic emotional systems there, and they were all in a negative overdrive state. So she had to be taken away from that, out of the drive state. Which is what we did, and you can see on the capnogram how rapid that was. Matter of seconds, pretty much, and she was not in that state any longer. Once that was there, we need to consolidate this new state, which is how you build ego strength. You build ego strength through experience, not through thinking differently, not through a virtual model. Somebody needs to feel better. And as we've always said, you ask most people who are suffering, would you rather think better or feel better? The answer is overwhelmingly, I want to feel better. And when people do feel better, then their thoughts look after themselves because homeostasis rearranges the kinds of thoughts which constellate. When a person feels that they cannot control their own environment and their own life, the thoughts go into a cognitive loop. That cognitive loop is a repetition compulsion, and it can't solve the problem, but it just goes on because people feel, or they think, they are told that you have to think your way out of this, you have to think differently. No, they have to be allowed to enter a state within which they feel differently. Once they feel differently, homeostasis then is getting the hint that this is the desired state. This is where we should be. And the thoughts will look after themselves. Very, very different approach.
I think another important element in that case, specifically, Steve, too, was that the decision to have the abortion would not have been taken at a cognitive level alone.
No.
In fact, a lot of instinctive decisions literally happen at that level.
Yeah.
And then cognition is literally like an afterthought. We
Yes.
believe that we are personally making the decision to do something. And I think particularly in that situation, because it was a rape and you know, an incredibly traumatic experience for her, that was an important part of allowing her to move on, because it's a kind of thing, I think, particularly clinically, you've got to be very careful about taking any kind of moral position towards with respect to the individual that you're working with. And it's like that with a lot of instinctive things. You know, there can be a lot of rumination after the fact cognitively about why something happened, but when it comes to instincts, sometimes the decision is made for us.
Yeah.
And simply just understanding that can be helpful.
That's hugely important. Thank you for saying that, because when people feel guilt and shame, although we can say that both of those are almost kinds of conserved affect, ancient responses, and so therefore instinctive at one level, our interpretation unconsciously generates something into guilt and shame.
Yeah.
And that interpretation is not cognitive, as you say, but it still emerges. And very often when people suffer from guilt and shame, they add a cognitive interpretation of something which has already been misinterpreted at an emotional level to that, squaring the error. And they feel there's no way out. There is a way out. We have to get to the source. And I don't mean by regressing back in time, but going into the genome and the meta-instinctive understanding of the situation, of why it will present something in that way. And here's one way that it happens, how it starts. When there are a number of conflicting interests with respect to the organism's understanding of itself as an instinctive and genomic level, when there is conflict at an instinctive level, there will be a default shift towards an optimal baseline state that will support survival. That is like a switch, and it is thrown, and then the behavior is released. The person does something, and then they feel guilt and shame. The guilt and shame is downstream, and that's a response when the cognition is not caught up with an understanding of why the decision was taken. In the case of an abortion for rape, as you rightly say, that's very often not cognitive. Cognition is an illusion. It's added on. And in between that, the guilt and the shame operate as affective responses, because cognition's made one adjustment, but it has not made a full enough adjustment. Because when cognition works on its own in a vacuum that is occupied only by itself, it can't feel anything except as an abstraction, which is a separation. A separation is a dissociation. A dissociation is a neurosis. But when a person can communicate in the right way, directly with the representation of the genome's understanding of itself, then there is no dissociation, the gap closes, and we have a superpositioned understanding where nothing is repressed, but everything has its place, that is rational at a deep biological level, which should then make sense psychologically. So in terms of describing it, that's what you do. You make that kind of understanding available to someone, and the way that you do it is not through CBT. It's by utilizing natural trance states so they can access the force that comes from within that is interested in resolving everything. So every instinct has its place, every response has its place, and meaning at those individual levels becomes a whole field of meaning, which is a summation of that in a positive way. But when the ego goes all cognitive about these kinds of experiences, then it starts to invent self-judgment on the inside, and then it interprets the culture as judging it externally, extrinsically, and it may do, but sometimes it doesn't. Sometimes this is a fantasy, an ego fantasy or ego fiction. So we need to get in touch with the genome and the emissary of the genome, which are the instincts, both meta-instinct and pansapien, as they occur at each level.
And this lady went on, as I understand it, to have a very happy and fulfilled relationship with someone, and to have more children. And so in that sense, her meta instincts to become a mother were repaired, and to have a happy and meaningful relationship.
Yeah, so she's a very successful professional artist, living very comfortably in terms of what she's earned in her life. She's married and she has 3 children. And she's achieved that herself because she did the self-correction that was necessary. She was provided with the means to do it, but she put the work in. She achieved it. It came out from her. And that then literally seeded the rest of her life thus far over the past 34 years. So that's a success story because it shows how a person can, with the right help at the right time, make the necessary adjustments to themselves so that they access the whole bandwidth of their intended trajectory for their lifespan development potential, and not ruminate and go into a cognitive loop and generate and then ruminate over guilt and shame as an intermediary stage between an ego that doesn't understand anything other than itself, and instincts which are trying to push forward an understanding of the complete situation. So these things are super important when it comes to helping other people. And if anyone's gone through anything like it themselves too, if they can adopt that as a general model of understanding, they can take the first steps towards correcting for how they've been hurt and how they've been abused by others.
I'm very interested further in the psychodynamics of what went on in that case, because as you say, it's so multi-layered. So my understanding at the moment is fundamentally there are these Panksepian drives, the so-called 7 basic emotional systems. Now, as you guys model that in psychosystems analysis, is not synonymous with how the affective neuroscientists and neuropsychoanalysts use those terms, but we use those for a moment. Those are drives that are always going to be pushing within a person. You know, they say that seeking is always on, but the other 6 are going to be variably moving in a waveform pattern. So these will push forward in anybody, but the experiences that people can have, such as that atrocious scenario that you described there in that case study, that in order for the ego to be protected and not be shattered by that, a complex forms, a Jungian complex forms, that's bio, psycho, and social. So presumably, there are aspects of it was biological and psychological that people may have been focusing on before when you say that she was medication resistant and stuff like that. But the effects are going to be superpositioned all the way up and down the biopsychosocial stack. And it's that complex then that essentially interferes with those Panksepian drives pushing forward and has its own understanding formed in a Jungian sense in the moment, and which basically just scatters them all over the place. And in a state like that, meta instincts cannot come online. Now, if that's a correct understanding on that, I'm very interested in what is within, so too is without, a saying that you guys use a lot. Some people will have support, let's say, from whoever it is, their parents, for example. Other people, like this case study, they don't. Some people will have, say, a relationship, other people will not. So the psychosocial factors are going to be different. How necessary or important is it that there is something there in the psychosocial environment to help homeostasis, and in particular meta instinct, come online? Because it sounded like from the case study, and obviously I don't know all of those details, but it really did sound like she was in such dire straits that healing, that came from within. And you guys helped with that, but the healing came from within, and it wasn't really supported by anybody else in the outside world. I find that fascinating for a sense of internal healing to get somebody ready for then Panksepp and meta instinct to release itself into a new adaptation that doesn't actually exist at all. If you follow what I mean with that, the importance of inner and outer.
Yes, that's very, very important. And it highlights the context specificity of this particular case. And that's important because we need to move beyond only that. But what we have there, as you rightly say, is a breakdown of psychosocial support, or at the very best, a failure of it. She was referred to me within the medical practice that I worked at by her GP as a last resort. So I was kind of anticipated by her as another failure, or as someone who would act as the figurehead of the healing that would come from within herself. She wouldn't know that probably consciously, but the anticipation would be, this is all or nothing. What can I do? I'm completely desperate. Everything's awful. Everything's dreadful. So what I can say is that I picked that up without knowing it the moment she walked in the door. Made eye contact with her, and I kind of received something which was a field impression of that person's whole situation in a fraction of a second. And I must have returned something, because she I detected the counter return as well. Now, what I did know and do know, and certainly knew at the time, is that this is the opportunity that I've been given, but the responsibility that I've been given as well, because that could go a number of ways. It could have just collapsed into your typical psychoanalytic transference, which would mean then that she would become dependent upon me for a long-term form of psychoanalytic, psychodynamic psychotherapy, which would be pointless. It would be utterly pointless. Although she did have classic Freudian symptoms, and by that I don't mean in the way that most people might be familiar with it, but she had the somatoform representation of her traumas. Remember, Freud and Breuer, in studies on hysteria, put together cases and their experiences at that time of this kind of thing, how things like sexual abuse and rape and childhood experiences became somaticized. So that was immediately apparent, but they didn't have a capnograph. They couldn't do that. That wasn't their fault. The technology didn't exist, and the science behind the technology did not exist. I had the machine there, and I thought, we've got to go on this pretty much immediately. I did have a case history because that had been given to me by the doctor, and I'd read the notes before she came in. But before the person comes in, the notes are abstract. When the person comes in, the notes and the person conjoin together. They either fit perfectly or there's a mismatch. Usually there's a mismatch because the totality of a person is more than any note that can be made about them in a medical sense. So I had that as preparation, but that immediate eye contact and how she responded to me as a human being with a field around me, which I was obviously giving off, part of the role that I was in, that was the, as I say, the responsibility that I felt in that immediate moment. We have to get that. I've got to do that. I have to do it. It is my duty to do this.
Do you think she intuitively felt you understood her?
Oh, definitely.
Yes.
Yeah, I could absolutely tell, because the moment she came through the door, we exchanged that glance and unusual pleasantries. She walked across the room and sat down, and she looked at me again over her shoulder. And I thought, I have to do that. I've got to do what is necessary for this person. And everyone you meet is different, you know, and I've obviously had that experience with many people. But specifically about this, it was very, very marked. And we got on with it immediately. But the extent of the collapse of her CO2 and her acid-base regulation was so dramatic. And the alarm was going off on the machine, and now we are going to have to do it. We're going to have to get into the way her system is regulating itself. We have to separate her from her physiology. So her physiology can't feed off her ego, cannot feed off her complexes. We separate them, there's no connection. When there is no connection, there is no communication. The field of the complex has been disrupted when you do that. So that's what we did, or I did, I guess, in that moment, and that resulted in the immediate effect that you can see on the graph. And that maintained itself. Once it had maintained itself enough, I thought there's no need to keep this going beyond the point where she herself can see it. She can see it, and her state is different. That now is paired to her relationship therapeutically to me. That's what I need. Once I've got that, I can reconstitute that outside of that state and bring the healing processes on side. And she was recapnographed, and she was at the end of the process, and she was absolutely fine, and all the symptoms had gone. And she had an integrated ego at that point too. So in that sense, it was a really clear case study. And I'm very grateful for having had that experience, because it was so dramatic. Not all capnograms are that dramatic, but they will show various things. They will show complexes active. They'll show the defense mechanisms kicking in. But with her, there were no defense mechanisms. Pretty much it was gone. Their capacity to regulate had gone. This was someone in a dire state of their life.
So there's a coherence between the transformation that she experienced and what she could see visibly in front of her eyes on the capnogram, and as a form of biofeedback, really, which is very reinforcing, isn't it, positively?
She could see the waveform on the capnograph, the actual capnogram itself, capnograph itself, plus the values, the respiration rate and the CO2 values, completely different. Nice level respiratory curve, not this, nice up and level. So she saw an immediate change and felt an immediate change. At that point then, any transference that would have gone off into a psychodynamic one and been pointless had been converted into something that would be effective. And that's one of the main differences with traditional psychoanalysis and what we do.
Absolutely. I mean, the capnogram speaks for itself. That bit at the end where it's the best CO2 value of that entire session by far, and it's stable. And it didn't take that long. It was a couple of minutes from memory to 1 or 2 minutes for it to get into that state. And that suggests to me that despite everything that she'd been through and was currently going through, homeostasis was right there and ready to go. And I'm reminded, I think we discussed this in our most recent video, Resolve Your Anxiety, that we put out, when we discussed transference in there. And because the point on transference I find really interesting with this, as part of that, the psychosocial variables that someone will have, or someone has the potential to have, that transference is not good. Transference will, it always looks to confirm itself. It's not an attempt to try and heal oneself. But the intuition behind it, pushing it forward, is looking for the actualization of the person. So if I'm modeling what you say correctly, Steve, it's as if there was an intuition within her field. There was a potential for that to come out as transference, but you handled it so well that the transference didn't have to come out at all, and the intuition could come straight out, work with you and bounce back, basically. And it's as if that was very, very important, that was needed, in a sense, that because of the psychosocial aspects that she was going through and had gone through, she needed somebody else on the outside for homeostasis to confirm itself off of. For modeling that right?
Yes, you are. Absolutely.
How important was it, if at all, perhaps not, that you were a man rather than a woman being in that role?
Well, what I can disclose is that the name of the rapist was the same as my first name, and she knew my first name, which was potentially a confounding factor. And a more traditional psychoanalytic perspective would have played all over that and drawn out the negative aspects of her relationship to her rapist, whereas I was not at all concerned with that. Not at all concerned with knowing anything about this person. The fact that she was raped and there was a consequence to that was the most important thing. How do we remove the consequence, not we go back, because that would generate all sorts of things and a whole line of regressive attachments to past relationships, including her parents. So knowing her parents were also a problem to her. What would be the point of making me a problem to her as the recipients of what was transferred off from them? So my view is we have to help this person, we have to get them right. And part of that mindset I carried forward from my police work, because I was always interested in relating to people, and I always led with that when I was in the police. Rather than policing them, I was there to support them and do the right thing. It's almost as I was trying to be a homeostatic agent within a law enforcement context. And I did that many, many times and solved a lot of problems for a lot of people in a lot of ways by moving with and through the field of the area, the very rundown inner city area that I was working on my own in such a way that it brought changes about. And I learned a lot from that. And I felt it very much then with this particular case, that it shouldn't be about that. Because in the police, in those days, you got an awful lot of transference. You wore a uniform, then you were a pig. That was the initial response. You received immediate transference. So you could either try and defend yourself against that, and therefore defend other people you don't know, or you present as you are in the moment and be solution focused. And that was how I felt at that time. I've got to help this person. It's such a strong, I have to help. Rather than go through this boring, tedious years and years, which it is, and under normal conditions, psychoanalytically, transference, this person wants to be well. And what the heck? You know, so a positive transference can be utilized. That was positive because she gave me the capacity to help her for as long as she needed the help, and then there was no need for it. Negative transferences are different though, because they are interested only on in sustaining themselves. Positive transferences you can have the same problem with, but if you move a person towards a solution, then they move past the transference when it's positive. When it's negative though, it's worse, because they want to just simply sit in that and blame you for everything that's ever gone wrong with them and with their life, and even with their own understanding of themselves. You become the object of that, and it's all transferred onto you. That's a sickness. That is a neurotic sickness. But I didn't read that in her eyes. Didn't read that. I read someone who was desperate for help, and in that moment appeared to give me permission to act responsibly towards helping her to homeostatically re-regulate herself. And that's something psychoanalysts do not do. Whether they're Jungians, Freudians, or whatever they are, they don't do that. They're not there for people. They're there for the process of the theory.
Well, even back when you were a policeman, Steve, you were fundamentally a person first wearing a police uniform,
yeah.
weren't you?
Yeah.
And that's how it should be in this field. We should be people first.
Yeah.
And therapists, academics, whatever, secondarily to that.
Yeah.
That should be the motivating force
yeah.
for anything that's to do with wanting to help people
yeah.
or be in service of people.
Yeah.
And I think what that does to that kind of field resonance that you describe, which is so fundamental to rapport, has an impersonal quality to it that moves you away from transference as well.
That's a really good point, because it does feel like as if you step outside of yourself. You're there. You're not at a distant participant observer. You're fully present. But you're fully present with a purpose, which is defined by the context, and you have to live up to it. That's the thing. You're called upon to live up to it, and then you go through it. A different configuration, people, different problems, all sorts would come in medical centres particularly, and every one you have to adjust to in a particular way. But this was very marked. It's instant. It's picked up. There's nothing left for this person, but she's giving it. Yeah, giving that. It's you gotta not feel it at the time. You have to feel it, but not consciously. The feeling's present, and so you have to do this.
You have to dissociate.
You have to dissociate yourself in order to manage the complexity of what's presenting and the potential issues. You can't be cognitive about it.
No.
But you do have to have an element of you that is in a cognitive state, superposition with the others. All these different elements of you have to work harmoniously as a field. And then you emit a confidence, a calm, quiet, relaxed confidence that the other person picks up on. That's super important.
Regarding the complex that was at work in this case, was there a particular reason why it superpositioned itself in such a stark, very dynamic way within blood pH? Was that to do with the conditions under which it perhaps formed, extreme stress, literal hyperventilation that perseverated, and that then forms the biological state encoder that also then the complex wishes to maintain? Is that the reason why, or is it something else?
Because it had a history to it, and because it joins things in the past with things in the present, and then things that occur in the future. And this is what I was saying about going to a first cause is not always helpful, because the first cause is not necessarily the first cause. It's just the earliest traceable association to the complex that is active in the present. Because complexes are dynamic, as you said, and they pick up things from the past to give themselves a timeline. If a complex can persuade the ego that it's always been there, then the ego is going to be less able to separate itself from it, because we identify with it under such conditions and say, it's always been me. I cannot separate myself from it. What I would say is, and this is just a position, because again, I don't always pursue things, I look for outcomes, is that it's likely that when she was raped, she was hyperventilating. And then the trauma of the abortion and the emotions, she either hyperventilated before, during, or after, or all three of those. And then that state became encoded either principally during the rape experience or afterwards, during the abortion or around it. It may not have occurred in relationship to the parents, but the thing that links it up is that once the acid-base state is constellated and it associates other things to it, then the recall of these other associations makes a person hyperventilate, even if they didn't at the time that they occurred. So the relationship to a parent became an issue of hyperventilation when it may not have been initially. On the capnogram, you can see she hyperventilates when thinking about her parents. So everything is a source of hyperventilation. It was probably the extreme trauma in this case that caused the association. And I think this is a good point to, or a good moment to help clarify for people what we mean by a field. When we talk about a field in this context, a field of superpositioned information, what we mean is not a field of one thing, the so-called homogeneous field, like in physics, where you have an electron field, and that's all it is. Here we have a heterogeneous field, a field of different things, and they are in association to one another. So they are connected continuously, and that defines a field of associated information. So it's information of different kinds associated together that forms a metafield, which is the representation of the activity of a complex, we can say. So that's what we mean by a field. And that's how I would answer what you said about the hyperventilation. It probably wasn't there in the early stages, but it became associated to it. And then the whole thing became a field connected by an acid-base disruption. So when we remove the acid-base disruption, suddenly the field has no ability to maintain itself. It can't configure and connect. And this is what that we talk about when we mention dissociation actively of the ego from different representational qualia that it has, like cognition, affect, interoception, exteroception. This is how both of those work together. The ability to separate, to detach from attachment to representations means that we can separate ourselves off from traumas and from complexes without repression. Because repression is when a complex is split off and it's separated itself, but it acts anyway. It's still there, it's still doing something. What we want to do is to separate the ego off from identification with the complex or by the complex to the ego. It can't bond. As it can't bond, nothing sustains it, because complexes are parasites. They live off our energy and our information, our configuration of life. If it's separated off from that, and there is nothing supporting it by way of identification, consciously or unconsciously, the complexes in effect are metabolized informationally, and they break down and they're gone. And that was the outcome for this young lady.
Thank you, Steve. That really helps clarify things on that, and that makes perfect sense, because if we think about someone who is actively, let's take an obvious case, someone who is really actively hyperventilating, say deliberately, as per these strange breathing practices that go around the internet at the moment, they will report, and obviously so, being in a dissociated state. They're in an altered state of consciousness. And so there is something innately dissociable to the field of the ego broadly for hypercapnic states within blood pH. So that makes perfect sense. You remove that biological factor through appealing to homeostasis. Fundamentally, that was by hypnosis initially as you did it, and homeostasis then can work to remove that complex broadly, but very naturally. It sounds like it wasn't targeting a complex in a sense, or nobody was targeting or challenging a complex directly. It was all through appealing to what should be naturally all along.
That's a really good point. And because the complex was so traumatic, the core configuration of it as a field, as it was presenting then that was its weakness. If it is so distributed between different states that the associational field that makes up the complex has to be approached in different ways in order to find that little piece of Jenga that you pull out and the whole thing comes down, then that is different. And it can take a little while longer, but not much longer if you do the right things. But this was so clear, so very, very clear. And as I say, the main takeaway for psychodynamic orientated therapists on this is that the transference, you should never, ever, ever go looking for it. You should never elicit it. And if it's offered, you should seek to understand its purpose. Because the purpose behind its immediate presentation will always be some kind of self-cure, as Jung said. And as Jung said, it's misfired. That says what it is, but it still doesn't solve it. We have to find the meaning behind it. And to do that, so long as you have a good enough therapeutic relationship with someone, you should not pathologize the transference. You should work around it. But too many psychoanalytic orientated or psychodynamic therapists want there to be a negative transference. They want that. And from that, they infer all sorts of past relationships and then locate the disturbance in childhood experiences, which causes the ego to regress into childhood ego states. They become vulnerable. And of course, the therapist is the parent. And they become dependently attached to the therapist. That should not be our intention. It should not be the outcome of therapy. And what we're looking for with this self-regulatory metafield, which is rooted in the genome and its immanent regulatory fields, is what the Jungians understand as the self-archetype. But they can't approach it in this healing way because they put so much nonsense in between the direct experience of this organizing principle within the personality and the patient. They put all these mythologies in the way, and they lack the capacity to relate naturally according to how the psyche presents itself. And it presents itself in different partition states. The partitioning is the key. You get very, very little progress if you talk only to the cognitive part of someone. And you get virtually little more progress if you just talk to them in an emotional receptive way. You're still within the field of the ego or its conjoint field of complexes. And the complexes can play all sorts of games with you forever if you're not careful. But if you can access, and it is relatively simple to do if you do the right thing, that homeostatic self-regulating principle, then that which the Jungians seek is immediately present, as it was for that woman within seconds of walking in the room. But if they say it's impossible, you've got to go through the shadow, and she'd have to go through the animus, and that would have to be analysed, and you bring all sorts of mythological stories in and get her to tell you her dreams for years, the girl would be dead before any kind of effect had been brought to any kind of conclusion for her that way.
It's deception, isn't it, really?
It's self-deception.
It is a deception. Yes, it is a form of deception. To generate the illusion that something has to take that amount of time when it simply doesn't.
No.
I mean, that in and of itself would evoke a trance state.
Yeah.
And suggestion, auto-suggestion will probably do the rest, unfortunately.
Yeah, that becomes a complex,
doesn't it? It does. Yeah, I think just to come back to your analogy about the Jenga, about removing the piece and you know the rest of the stack falling down, presumably then maybe just to sort of elucidate a little bit more that in this particular case, because the thing that was removed or the thing that was re-regulated, which was the acid-base balance of our body, was so fundamental to everything else, was holding everything else up in effect, was what allowed you to have such a complete solution to the problem for her. But had that been a different scenario, whereby, you know, something is teased out and dealt with, but it's not pivotal to homeostasis necessarily, then the neurosis, the complex, will continue to exist in other superposition forms that haven't actually been touched by the intervention. That can happen as well, can't it?
It can happen, and thank you. I'd like to move on then, James, to another case study where pretty much that's the case. It had been so long established that the woman wasn't particularly hyperventilating at all, and she had completely somaticized, and the partitioning was in that state then, and the approach to her was very different and had to be different. But there was still that understanding of this is the problem that we are being confronted with. We have the conversion of a severe trauma into a purely physical representation that was so stubbornly resisting everything that it had to be concealing something that was the original cause, but the original cause was long, long gone. And she was now suffering from the symbolic representation of that trauma.
In World War II, a young German woman witnessed the British RAF firebombing her city, destroying buildings and incinerating people in front of her eyes. Shortly after the war, she fell in love with a British soldier, married him, and fully integrated into British society. Soon afterwards, she developed intractable irritable bowel syndrome. Over 30 years, doctors found that they were incapable of helping her. But the psyche always represents itself. With just the movement of a finger under hypnosis, her symptoms were gone.
So this lady was born, I think it was 1920. She was the same age as my mother, actually, strangely enough. And when she came to me, she was 75 years old. And she'd had irritable bowel for over 30 years, and it was intractable. She'd had all sorts of treatments, and again, the doctors have given up. And she was a personal friend of a GP at the practice that Paul and I were at that time. And she was referred to us in the hope that we could do something with irritable bowel, because the GP for hypnosis could be valuable in helping someone relax. So once we received the case study, which you do, or the case note in advance, then it was pretty much immediately clear that she was carrying something in a symbolic form that was being represented that way, because this is with irritable bowel, because she'd had all of the investigations. And as often happens with irritable bowel, there's no immediate solution medically to this. Why does it occur? It was a mystery. But it was also obvious that she was born in Germany, and she'd married a British soldier just after the Second World War and come to live in the UK. And I thought that was significant, but I didn't want to push it with this elderly lady, because she had other problems, other medical problems. And if there was something stressful behind it, pushing her to the point where she might emotionally abreact could have caused problems. As we've discussed in other videos, that has happened in some medical centres that we've worked at, where nurses have even indirectly brought about an abreaction, an emotional discharge in an elderly person whilst they're on an ECG machine, and the ECG tracing picks up an ischemic event. In other words, they're having a small heart attack in real time, even though it's not being felt by the person. Something is going on which is not very nice, brought about by a very slight emotional discharge. So having got the case study from this lady, she was at a loss to explain herself what had happened, but she told me that she'd gone through a firebombing, immensely traumatic one by the RAF at night, that caused a firestorm in the city that she was living in. which sucked all the air in and causing hurricane force winds to lift people out of buildings, to pull buildings apart and pull human beings en masse towards a central conflagration where they were incinerated in a big heap. And she'd witnessed this, and that had been massively traumatic, obviously beyond anything that I could have any kind of living connection with other than a virtual representation. And what my mother had told me about the bombing in Liverpool in the Blitz 1941. So I knew I had to reach this lady somehow and find out why she had irritable bowel, and I suspected it was that. I didn't want to suggest that it was, but we used hypnosis. We used Chevreul's pendulum first. We got the agreement that I would be allowed to help her and the rest of it. We went into hypnosis. And sure enough, in that state, while she was dissociated, she told her story, which was that she witnessed this and then she married. She actually was genuinely, it's a love marriage. It wasn't forced in any way at all or arranged or anything like that. She fell in love with a British soldier in the Army of Occupation after the end of the Second World War, came to live as a British citizen, and nobody called her a Nazi or a fascist or anything like that. They all thought she was great. She was fully integrated into society. And she was like that for a number of years and then started to develop irritable bowel. And then it increased in intensity until it was crippling, and it had been sustained that way for 30 years at least. And nothing had helped her. So I suspected, without communicating to her, that was a representation of conflict between marrying into a British soldier's family, coming and living here, being accepted by the people, and then something else that had a completely different belief and impression about what British people were like as a result of the trauma. So we utilised hypnosis, and I asked for any emotion that was connected with the trauma of experiencing the firebombing and the subsequent conflict to be released safely without her having to feel any of it. And that it could be discharged through movement through her finger if the unconscious mind agreed. And meanwhile, she could just passively watch this happening with a lot of interest, but with non-attachment to the process, and certainly nothing occurring within her body other than that isolated movement. And that's what happened. And her finger moved and vibrated really rapidly for quite a long time. And then finally, it just stopped and relaxed. Then I terminated slowly and gently, paced it properly, the hypnosis session. And she was then able to come out, having told me the story and gone through the release, saying she felt much better. And her GP friend at the practice, the doctor there, I could name it, but is it worth naming it? Does it matter?
Probably not. No,
Probably not.
She didn't help her, did she?
She didn't help her.
No.
The doctor reported back that the symptoms had gone completely for the first time ever. And she was, what did you do? And I said, well, she just divided herself for a short period of time, whilst one part that didn't feel anything felt everything that she shouldn't feel, and then allowed it to drift away with a floating finger. And of course, that's not something that a medical practitioner can have any kind of congruence with, because it's outside of their experience. But the importance of that is to separate off the effects of affect and trauma from the ego's perception of it and of it registering within the body. Very often stress is in the body and not registered by the ego as stress, but it still has an effect on the body. And that was what I wanted to do, and that was part of the hypnotic induction, is that she would be completely separated off from that, and it would not be registered anywhere except in the movement of the finger. Because an abreaction, that is to say an emotional discharge under hypnosis, can actually amplify the intensity of the emotion. The emotion as felt is also somatic. It is in the body. It's superposition between the mind and the body in the context of the moment itself. So it is biopsychosocial. It's part of the therapeutic encounter at the dyadic level. But if you can separate attachment off from that, then it's as if the field is reconfiguring, and the symbol, the expression of that, is the movement of the finger. And in those circumstances in that moment to do with that kind of presentation, and made the clinical judgment that it was necessary for her not to feel anything, because it's not necessary for her to feel anything. And that actually would mirror the process of what had happened. She no longer had an affective connection to the representation of the firestorm as being irritable bowel. So she was already separated from it, but it had left behind that partition symptom and representation that was still active. So by not asking it to make the connection and then reconnect the emotion and then apparently discharge it, but likely just to kick off a psychosomatic storm in her body that could have brought about something awful, you know, like an ischemia, either then or later. The work of Norman Kaplan, an American cardiologist, has pointed out the dangers of death by abreaction. This was very firmly in my mind. I had to build up that trust and communication with a psyche, which obviously by then I was very well experienced at doing, and I was comfortable about doing that and about the necessary stages. But she had to feel comfortable with that too. And the preparation for that was the confidence her GP had in me, which helped. And then the experience of Chevreul's pendulum, which is a light form of dissociation that a person can experience while still fully aware. And then the induction of a formal trance and a deepening with a wider separation that matched the original separation, but did not allow the irritable bowel syndrome to reconvert itself into an affect which would endanger the stability of her ego and of her body, but release itself differently in a way that did not require feeling. So I've explained that a couple of different ways, but it's the same thing. And very often with trauma, that's the most effective way of dealing it, particularly a very long-term one that has become so symbolically registered that talking to it at a cognitive level will make no difference, and accessing it at a pure affect level would endanger her health. I had to deepen the dissociation and needed the trust from the lady to do that and to work with that. And to do that, I had to use the environment that she was in, which was the medical centre, which was her doctor and her personal friend, her confidence in me, and the specific way that the room was arranged, which we've discussed before, James, I think in videos, on how that you generate the most receptive and healing experience you can for someone. And all of that then feeds into the field of the therapeutic interaction you have with someone. And that's how that worked. And it's different in kind to how my mother and my auntie Lily dealt with the bombing in Liverpool, which we also covered in the last video, where my mother dissociated in real time to the extent that she wasn't traumatized. She naturally dissociated with bombs going off all around her by turning the sensory experience into a different meaning. It was like bonfire night. You know, or 4th of July if you're American, you know, fireworks and explosions and things going off everywhere. And I know buildings were catching fire and falling down, and people were being killed nearby. My mother was not in a state of receptivity to the suggestion of those real facts. She was in a different state. Lily, however, was in panic state. She was in full-blown Panksapian panic and trying to climb up the wall of the doorway that she was in. And my mother talked her down gently by just simply referring it to something else that had a different meaning. I don't know if my mother's always been like that, but she was always like that after that event. And as Pauline met her more than 30 years afterwards, she was still like that, wasn't she? She still had this capacity to dissociate.
She did. I mean, I would argue actually that was very adaptive. Yeah. And of course, you know, dissociation is adaptive to an extent, otherwise it wouldn't occur in the way that it does for people in an ordinary everyday sense. So you know, there are benefits to having the capacity to do that. She did it par excellence. There's no doubt about that, with apparently no ill effects. So we can only assume that in a homeostatic sense it went just as far as it needed to go to correct for any kind of negative effects. Of course, that's not always the case, and everybody is different, but it certainly served her well. That's for sure. You know, we might as well, as I think you've been at pains to say throughout the whole of this, Steve, we might as well use that to positive effect to help people to heal through reassociation. It's such a simple process, such a simple mechanism, really, but it's very, very effective. And because it's based on something which is natural, then the person's system as a whole is unlikely to resist the process. It tends to want to go with it. So there's a lot of advantages, really, to dissociation.
There are. So as a ground state appreciation of dissociation, it is adaptive.
It is.
I would think that it's quite rare, though, what she did. I don't think there was anything special about her as a person other than the fact she could do that. Because most people, when they dissociate, do so in a more negative way.
Yes, that's true.
At least in a clinical sense, when we see the people who have failed to adapt through dissociation. But the capacity to dissociate, that is to partition parts of our self, our ego self, and say, you deal with that, I am busy. And then while you're dealing with it, consolidate, if you like, into a functional unit which will deal with future similar events. That's how we deal with a lot of things. But sometimes they take on a life of their own, in effect, and their autonomy is such that they then start to attack the ego if the ego does not agree with the setup instructions of the complex. And that's your typical complex. At a psychological level. And then when it starts to somaticize, if it completely vanishes, as happened with the lady from Germany, then it invariably becomes a symbolic representation of something. And with her, it was the knotted, twisted bowel of conflict between two completely diametrically opposed opinions about British people. One is that they are mass murderers, and the other, they're wonderful. And she could not reconcile them. So her dissociation just sank down below the level of consciousness over a period of years, and then finally represented as an irritable bowel, which then became the symbol for everything and anything that could be connected to it. So the first cause there was important, whereas in the earlier case, the girl with the capnograph, the rape and the abortion and so forth, the first cause was not important. So again, we have to be specific about what presents and what you look for.
And the pathways that things take, because in that particular case study, everything in a Rossi sense, it was likely psychoneuropeptide, probably. But in other cases, the psychological material will take a different path, a different route. I mean, when you're talking about the firestorm, it actually made me think of cytokine storms in the body. So that immunological response or overreaction by the immune system sometimes, and all the symptomology that follows on from that is another way for things to be registered. And the thing is, these pathways are real, even if the representation, the physiological representation in terms of the symptomology it's real in the sense it's experienced, but not real in the sense that it is reflective of disease process. But I think your point earlier, Steve, too, though, that where these things persist in that way, where, that becomes a regular way for that individual of dealing with a particular stressor or traumatic situation, then there's a kind of a crossover point in which it becomes the beginning of something else if we're not careful. So I think if we catch things at the point at which they're symbolically represented, then we can reverse things relatively easily. Sometimes people go over that threshold and it becomes more difficult because it becomes disease process in the body. And, if we go back to, again, to some of the early pioneers that we're talking about before Charcot, Janet, and others, things like catalepsy, for example, when that obviously has to follow the physiological pathways that exist to allow it to be expressed in that way. And if we take maybe a more modern perspective on that, it might appear like that as purely a you know, a paralysis as such, but it might also take a more specific form, so that it mimics something like a hemiplegia in a stroke.
Oh, yeah.
Or hemiparesis, you know, a paralysis, say, down one side of the body. Yeah.
Can I just say that
yes.
there is a case of that, so to speak, of that nurse, wasn't there?
There was indeed. Yes, there was. Yeah.
Shall I mention
yes,
that?
You can
Briefly?
do. Yes,
briefly,
of course. Yeah, it does illustrate it.
And this was a trainee who was a nurse who was working with us. We were running courses in medical sciences, but she was a student that was with us throughout. But she worked with stroke patients, and the suggestion was given so she could experience hypnosis, that the temperature of the skin on her arms, her two exposed forearms, would be different. One side would be cold and one side would be hot. And she received that suggestion and then amplified it out, so the whole of one half of her body became cold, as if she'd had a stroke and she couldn't move it, and it was so had paralysis and lack of sensation. She basically replicated.
She did,
through auto-suggestion, by expanding on an initial suggestion, something that would make sense of that, given her context as a nurse. So that's an example.
Yes, a very good one. Yes.
Yeah. And very often people will make sense of things, or nonsense, through representation of suggestions or influence within the culture, or within a family or a relationship, or just spontaneously generated within themselves, to do as a representation of something they don't otherwise understand. So there might well be a novel situation that can't understand this, so suddenly it becomes something else, as if that's trying to loop back and say it is like this. And that's one way that you can deal with people who have so-called hysterical symptoms, is to bring them into understanding that the representation is like something, but it isn't really. This is meant to draw your attention to that which is other than it, that is in the background. But there's no need for you to, of course, feel or think about this, because what the psyche puts there, the psyche can take away. And that's part of the preparation for someone, so they can feel it is not necessary to be upset by anything or to become distressed or anything. The re-regulation can occur spontaneously, but you will be left with a very gentle understanding of the meaning of the symptom, so you don't have to use it again any further in order to attempt to bring understanding to yourself. Very important ways of clinically managing things, so people don't feel that they are being told there's something literally wrong with them at the level of character, that they are insufficient in character, that they are weak. You know, some of the old doctors in the 19th century used to talk about an innate weakness in people who produce hysterical symptoms. I think that's completely wrong. It's just a normal extension of our capacity to dissociate, and to take that dissociation and utilize it so it solves itself is the way of dealing with that when that happens.
Well, what we probably haven't addressed, Steve, sufficiently in all of this, are those people who tend to represent things. They may be representing things physiologically, maybe just purely in the form of a drive state, that they're aware of a drive state in the body, but the representation is overwhelmingly psychological or cognitive. So say somebody with OCD, for example, might experience themselves in that state. So there's the preoccupation with the ideas as the rudimentary side of things, so that the trauma is represented principally in that way. But there is a physiological concomitant, because that person's aware that they're anxious and that is an unpleasant state to be in. So that they will also potentially form part of this coming psychosomatic storm in a way as well, which we see to some extent as arising principally out of the culture and the kind of repressive sort of political regimes that we are forced to live within at the moment. And as they accelerate and become more repressive, then there will be some people who, if they're not prepared for it, will be caught in that way. as opposed to the ways that we've mainly been describing.
Yeah.
So the idea that they can't, that certain thoughts are inadmissible because it's wrong to think in a certain way about things, that may then act retroflectively against them as a psychodynamic, and also be experienced in the body, as I say, as a principally as a drive state. As
so,
almost free floating anxiety.
It'll be described as that, won't it?
It will, yes.
Almost universally misunderstood by medics, unfortunately. Whereas the drive state is the instinctive compensation coming from pure form for something that's unacceptable to instinct.
That's right.
Or instinct is unacceptable to the state of the ego because of the suggestion it's received.
That's right.
Say from the culture. If it's top down, if it originates within the person, they can also suggest themselves into a state of repressing instincts. That goes all the way back to Freud and Breuer, and even earlier than that. So it's been well known about, but largely forgotten, unfortunately. So the psychosomatic storm then would represent itself in such people as a massive drive state. And anxiety is not an emotion. The emotion is secondary to the anxiety, which is the drive state, which is coming in a compensatory, pressurized form directly from the genome itself, that it's finding a situation intolerable, including the ego's attitude as being intolerable, which is where unconscious anxiety comes from, so-called. It's coming literally through gene expression. And the ego can't make cognitive sense of it, so it should give up on cognition. Instinct is the solution to complexes. Instinct is the cure for complexes, so long as you receive instinct properly. That's absolutely the case.
That Steve and Pauline, that case study's phenomenal, to be completely honest. I can't imagine at all what it would have been like to have gone through what that woman went through with the firebombing, let alone then that conflict that arose afterwards through marrying a British soldier. I'm very interested on that particular aspect of it. And when you said that fundamentally you could represent or understand what was going on for her through a very deep conflict around viewing the British or British soldiers, mass murderers, or lovely people. Obviously, though, it's not a cognitive split. It's not a philosophical thing. Are they good? Are they bad? That cognitive representation goes deeper than that and pertains then to fundamental instinct. And I was wondering if you could speak a little bit further on that and what might have been going on, because it sounds like initially, and perhaps for very good reason, the uncompromisable instinct for self-preservation and everything else that would cluster around that kicked off within her. So that's when the firebombing was taking place. Probably Panksepian rage, probably Panksepian fear, Panksepian panic/grief, all of those fundamental drives to go no. And there must have been some aspect of complex downstream to do with the associations with that, it sounds to me. And it's that then, that associative field, both of idea, but instinct fundamentally driving it, that made that conflict almost inevitable, it sounds like, when she then goes and marries a British soldier, and then everything meta-instinctive that would be anticipated. So presumably there would be obviously Panksepian lust in there, but everything it would mean to have a relationship, perhaps to become a mother, all of that kind of stuff. So is that fundamentally there, right down at that genomic level, really, just above it? You've got these two competing instincts, and they're being held in opposition by that complex. And that complex takes that pressure from both and ducks it down symbolically into the irritable bowel syndrome, so-called.
Yeah, that's perfectly represented. So the two instincts then are actually meta instincts, or we can consider them to be that. And beneath that, or between them, there is something which unifies both, and that will be a meta scenario for the meta instincts, which will be where on the one hand you've got very ancient Paleolithic, probably, or even earlier, representations of things like territoriality, and identification with tribe and with group, with them and us, and the fact that you could take that and what happened to her out from the specifics and into something which is very similar but very different at the same time. And that would be a raid by one tribe on another, and the taking away of the women. This has been demonstrated in the Paleolithic by genomic analysis of skeletons, the DNA from the skeletons of women who had been moved at some remove and had married into another group who were genetically dissimilar, that kind of thing. So in other words, the movement of women between populations has either happened to build up relationships or to break them and to seize territory. And to some extent, that's been conserved, and it's almost as if there's a genetic memory of that, an understanding at a meta-instinctive level that it could be either of those. And where it happens voluntarily, that's a good thing, and where it happens involuntarily, it's a bad thing. And where there's conflict, where they both appear to have happened or have complementary but opponent process meanings to them, you're going to get neurosis at an instinctive level. Because it's both good and bad at the same time. I can't bring them together. I can't do this. I may have married this person, but if the war hadn't happened, I would have married somebody else. These are the Freudian questions that you know, in a general psychoanalytic sort of opus work with someone, you would venture into if you were taking that particular path. What would your life have been like had there not been a war, or if you hadn't been firebombed, or you'd met a local German soldier, perhaps veteran, because they were all more or less inducted into the army at that time. You'd have had a different life. And she may well have been thinking this and then found that unacceptable and repressed that. So one pole of the competing meta instincts would take hold of that via a complex, and then it would express itself, and that would have to be repressed. And that side of the instinct would be saying the British are horrible, but the other side would say, no, they're great, they're wonderful, and you're one now, you are naturalised British. And the other side would say, no, you're German. Another side would say, but the Germans and the English are genetically identical, more or less. You are the same. And back and forth, I can't take this, woof, down, bang, into the body, and then it's represented at that level. So with her, it seemed that the confession of it, which she apparently had never done before, and then the release of that which was keeping the two apart and not able to bond back together, had maintained the symptom. So she'd never been able to confess it. She'd never been able to say, I hate them, but I also like them, and I love this one Englishman. Just couldn't do it. She couldn't confess it because she would have to betray the other pole of the meta-instinctive dyad that was in conflict. So her conflict was at an instinctive level, absolutely, a meta-instinctive representational level that was so ancient it was probably Paleolithic. And then it just turned up in her stomach as contorted bowels, a terrible suffering for a long, long time.
Steve, I can see some strong elements in there of, not reminiscent of Freud and Breuer, certainly in there. And thinking back, obviously, to their 1895 publication studies on hysteria, and even earlier, 1893, with their preliminary communication, they would essentially put people into a state of hypnosis and try and get that confession from them. So-called confession from them. But the most important thing that they spoke on was the person had to relive it. They had to re-experience that. But you've obviously demonstrated, no, they don't. They do not have to do that. Okay. Or if they do, it's not them. It's a different part of them that's partitioned off. And that's dealing with it, or that's feeling it metaphorically. But on the feeling point, because this highlights your guys' model of superpositioning of information, that instinct, normally when that fires forward, we feel that affectively. So as you guys say, affect is the carrier wave of instinct. But obviously with superpositioning, it doesn't have to be in that affective form at all. So with the case of this lady, it wasn't in an affective form within ego consciousness at all. It was in a different form. So that'd be fundamentally somatic representation, as per your model of the four qualia of ego consciousness.
Yes.
But deep structure, regardless of if it was in affect or in somatic, deep structure is still those meta-instinctive elements with that.
So the somaticization is going back even further than the affective brain. So that is an extremely deep dissociation when it goes that far and there's no affective connection at all. Whereas some people are aware of a somaticization and an unpleasant effect as being present at the same time. But it had been in that state of somaticization for so long, and there'd been no confession, that it was now only represented at that level. There was no conscious affect at all. There was likely affect there, certainly there, but it was not associated. It was dissociated in a negative way. When we do the healing process, we do dissociate. But what we had to do in this case was dissociate from its chosen form of representation, which was somatic, and prevent it from becoming associated then by being shifted into affect, which would overwhelm the ego. And the cathartic method that you mentioned that Breuer and Freud brought about is perfectly rational from their perspective, that it seemed to be that that would be the way of doing it. But they found, although they don't think they adequately addressed it, is that you can cathart or abreact. Jung called it the therapeutic value or not of abreaction. Same thing, emotional release. That it just boils up again. It's like you have a kettle boiling away, and as it's nearly gone into steam, someone pours some more water in. That's what happens, unfortunately, a lot of the time with a cathartic or abreactive approach to treating neurosis. We're treating the emission and not the source. And when that's affect, that's the problem. But we have to interpret and understand or redirect the affect so it doesn't express itself as affect. So the aim of the treatment was to turn it into an idiomotor movement, which would be the new symbol for the condition, but it would be time limited. The suggestion is this will move, and when it stops moving, it's all over, it's gone. You will be, in effect, dissociated again from that expression, but with a safe understanding of the meaning of why you had the symptom without ever having to feel it. And a traditional psychoanalytic view would be worried. They would think that will just reassociate itself. Well, it didn't, and it doesn't when you don't suggest that it will. If your method of approach suggests that that will happen, you then set off a further partitioning within the ego, and the ego then sets up a complex ready to receive this now redirected affect and then recharges up because the therapist has said that will happen. And therefore, through the transference, you generate another complex and make the situation worse than it was in the beginning. So she demonstrated a capacity to move the representation of the distress into her body. We then utilize the body in a different way, not somatosensory, but idiomotor. And then we let it move out that way, but leave behind it meaning. And meaning ultimately is not cognitive. The cognitive understanding of meaning is that the cognition receives a representation of completeness, and that completeness has occurred before cognition has ever grasped it. So when they receive it, they don't analyze it. They just know, I have received a sense of meaning and a resolution. Whereas if you say to them, you must cognitively understand this, they will generate a virtual model of what they now believe is behind what they received. And they alter what they receive by doing that. And it becomes another complex. So if they're encouraged to receive natural homeostasis and the understanding that it's all been done and you don't need to feel it, it's actually been solved. Your job is to live your life on the outside, not to overly interpret what you know, James, that we understand as being internal projection, where you fire inwardly over the unconscious mind and force it to react again to you because you're not receiving. And you know, the other thing we say is you must learn to receive and then follow. What you follow is the meaning of what you receive, which redirects your action in the world into adaptation. So receiving and then following by accepting understanding is transpersonal. It's non-ego. It's bigger than that. And that's very polite to do when something as powerful as the unconscious mind has said, we've sorted this. I give that to you. That's the conclusion of this experience of your whole being. And the mistake then would be, well, no, that's not right. I want to understand this cognitively. I want to analyze it and break it down. And it's like, what the heck have you done? You've just screwed it up again. You can't receive. Yeah? That's what an ego that exceeds its boundaries of proper operation will do, particularly if it's encouraged to do so through an emphasis on cognition, or it's told, as I mentioned just before, by some well-meaning but misinformed psychoanalysts that you can't do that, you have to feel it. Feeling makes you conscious. Feeling is independent of consciousness within the ego, because feeling can feel all by itself. It is a representation of information that is systematized, that does not have to be connected to the ego and does not have to be somaticized. It can self-regulate within the wider field of homeostasis. That is something that many of the contemporary neuropsychoanalysts need to understand, in my view.
It redefines consciousness, doesn't it?
It does. It does. It shifts it away from being only an ego phenomenon. Yeah.